the slides well. Well, welcome everyone. We see a lot of participants offsite. Great to see you all. Many of you have reached out last night. It's always amazing to connect to this very, very academic, highly academic group of doctors and researchers. Can you hear me well? On the other side too, can you guys give me some thumbs up over there? I hope.
I can hear you. I can't speak for the people in
Okay.
chat.
Yeah, I have a chat here. So if you have any problem with hearing us, please send us a chat. Okay. All right. So let's start. These are my disclosures. My objective that I want to share with you is actually to get familiar with the clinical spectrum of REC deficiency and immune dysregulation. I will focus on a gene that I'm very interested in, but I make sure that before that there will be some basics and some foundation that all of you are very interested in combined immunodeficiencies. We will talk about pathomechanisms of immune dysregulation a little bit, especially from the B cell angle, since B cells are the focus of my laboratory. And then we will gain some insight into mechanism-based monitoring and definitive therapies. And I have a lot of words in red. And the reason why I put these words in red is because they're complicated. It's very, very complicated to think about these disorders. And even for scientists, it's complicated, let alone for a clinician who is taking care of patients with regular allergic diseases, immunological diseases. So I think it's very important that we somehow meet somewhere in the middle and we help our colleagues to catch up. And it is hard because we have so much to do in our clinical life. So when I talk about these things, I hope you take something home, and I also hope that you will understand the importance of genetics, which is going to be one of my main focus in the talk, and the importance of understanding immune subset analysis. And the genetics probably is a bit easier to get done, although interpretation can be complicated. And immune subsets are, I believe it's a bit easier to understand, but much harder to get. So you have to pick your weapon of how you want to tackle patients. But I really hope that the conversation will continue between academic centers and the providers in the community, because without them, we won't find these patients and we won't be able to take care of them. So when I think of combined immunodeficiency and immune dysregulation, I think of history. And back in the 1990s, we all were looking for patients with immunodeficiency just based on infections. There was a very nice initiative by the Jeffrey Model Foundation and many other companies at that time. Vicky Model went to the Congress and said, I'm going to talk to you about the other immunodeficiency, referring to not HIV. And she wanted to have awareness about this disease. And as of 2018, we actually have in the US universal screening of newborn screening for SCID, the most severe form of immunodeficiency. So we have really come a long way to understand immunodeficiencies for the one who really had to be addressed right at the beginning. However, coming to 2020 now, we have very different warning signs for each individual immunodeficiency disorder. And for me, APDS is a poster child of these conditions. And what you can see that this disease, which is one of the many, monogenic inborn error of immunity, has only 4 of the 10 warning signs that is overlapping with the initial 10 warning signs of infections. And now we are talking about very different conditions and clinical features, such as persistent cough, enlarged liver and spleen, lymph node swelling somewhere in the body, autoinflammatory conditions, developmental delay in lymphoma. So the features of these disorders are no longer infections alone. If anything, many of them will present with atopy, autoimmunity, inflammation, and malignancy. And what we also learned from a very strong European cohort of 16,000 patients, that when they looked at this registry of all comers with immune disorders, the second most common initial presenting manifestation of inborn error of immunity was dysregulation. And how they defined dysregulation was very specific. They looked at patients with autoimmunity, cytopenia, thyroid disease, joint disease, vitiligo, alopecia, things that we may not even think of as an important feature of our patients, lymphoproliferation, splenomegaly, lymphadenopathy, inflammatory bowel disease, eczema, and autoinflammatory manifestations. So when you go out and talk to patients and families and providers, you have to think of immunodeficiency as no longer the infection, but maybe somebody who just had Evans syndrome. That means that they have cytopenias, ITP, and hemolytic anemia back to back or at the same time. In fact, autoimmune cytopenia is very important in the pediatric practice because we know that in some monogenic disorders, it can be the first presenting symptoms, such as in CTLA-4 deficiency. 33% of the cases of this large cohort from Schwab et al. Presented with cytopenia. So imagine that you would miss a patient by not evaluating at the time of their cytopenia, and you had to wait for the next 5 years or 3 years or 10 years before they declare the full immunodeficiency phenotype. So I think this is a lesson to be taken home from the beginning, that immune dysregulation is not negligible, and it is presenting in both pediatric and adult, even at an initial presentation of IEI. When we look at the IEI as a universe, it's pretty humbling and intimidating because we all know that the number of genetic defects are increasing. Of the 10 tables that has been defined by the IUIS, we find several different genes. And not only we find these genes, but depending on whether the gene has a loss of function, gain of function, haploinsufficiency, or dominant negative effect, there will be different clinical phenotypes. So in fact, the new report just came out, the 2024 report. You can search it on the web. And they found 559 inborn error of immunity. We are nearing the 600 mark of 511 genes. So you can see that the gene number is less. The disease is more because of the different inheritance patterns and the complexity of these variants. So when we come to combined immunodeficiencies, which is going to be the main focus of my talk, you have to think of this conundrum of combined immunodeficiencies presenting with so many different types of genes, different type of inheritance. And what is eye-opening to me is that you can find SCID genes in adults, and I will give you examples, that have less serious, not as aggressive form, but still have pretty significant clinical complications. And these combined immunodeficiencies can carry a patient a long life and not to be diagnosed until the monogenic cause is identified. And these patients would have high morbidity and mortality. And in fact, we have targeted therapies and bone marrow transplant for them. So when would you do genetic testing in your patients? I tend to hammer it into many of my colleagues and fellows. You really want to do genetic testing to prevent disease, to help with treatment decisions, to improve clinical outcome, potentially family planning. And it is up to, of course, the physician in their practice to decide who is the patient to sequence. But if you are out there and your clinician is confused about the need for it, I'm always in favor of going for genetic testing than holding it back from a patient. So one other thing that I like to share with medicine, with my colleagues in medicine, is to differentiate CVID patient for late onset combined immunodeficiency. So to me, combined immunodeficiency is an extremely red flag that I have to make sure that I understand and monitor those patients carefully. And to be able to sieve it out from the big haystack of CVID, you actually can do 3 different very simple things to understand CID patients. You can look at a B cell count. You can look at naive and total CD4 T cell ratio and genetic evaluation. And I believe that every CVID patient should have these 3 testing done at some point in their life, especially if they have non-infectious complications. And then through a multidisciplinary action, you would be able to have the early detection, mindful treatment, and monitoring treatment response. And monitoring treatment response is becoming a big question in our head, because it's no longer just a question of finding your patient and potentially finding the targeted treatment, but then you have to decide, is this patient ready for this therapy, and is the therapy working? So monitoring treatment response is a big question mark in our head in many disorders, and we don't have clear guidelines on how to monitor control of immune dysregulation in a patient with immunodeficiency. We have, of course, targeted therapies, and we actually steal all these biologicals from our colleagues in heme, oncology, rheum, and pulmo. We have only 2 FDA-approved medications currently that were designed for immunodeficient patients. The first one is leniolisib, which is a PI3 kinase inhibitor, and the second is mavorixafor, a CXCR4 antagonist. Besides these 2 FDA-approved medications, we don't have any other biologicals that were trialed specifically on immunodeficient patients. So whatever else you're going to be using are actually taken over from another discipline with very different type of patient population. So we have to keep that in mind when we use these medications. We even have to sometimes dose them differently. So how to differentiate CVID versus CID patients, and sorry for the typo. So CVID patients, unlike CID patients, unlike CVID, will have a higher likelihood of splenomegaly. So I recommend that in your CVID patients, you check for the size of the spleen. They can have granulomas in separate locations in the lung and other organs. Often they have gastrointestinal disease, autoimmune enteropathy, and lymphoma. And even on immunoglobulin substitution, they require more frequent antibiotic administration, hospitalization. How can you, again, save them out of the big CVID group? Marked decrease in CD4 T cell count, severe defective naive CD4 T cell fraction, and marked decrease in B cell count. So this is a 2009 paper from an infectious disease group, actually, from France. And I believe that it really set the stage for this important distinction of the two different groups. And when you think about CID, there are many things that you can do laboratory-wise to understand these patients. Of course, you would have the clinical history first, so you would look for specific information, such as herpes infections. EBV, CMV, fungal infections could point you towards a CID patient. And those CID with immune dysregulation will have autoimmune cytopenias, rheumatological disease, splenomegaly, and malignancies. So most of the time, we can't do this alone. We have to have a multidisciplinary clinical monitoring of the patient with the infectious disease, hem-onc, pulmonary, and rheum. And these disciplines are less likely to do deep laboratory evaluations. My colleagues in hematology are very shy to get lymphocyte subsets, and rheumatologists are not that eager to follow B cell counts, even if they have been using rituximab therapy. So it is really us who have to encourage them to go and get those labs. So for the infections, you would get immunoglobulin levels and vaccine titers, the viral loads. For autoimmunity, you can look into autoantibody profiling, specific immune subsets, which I'm going to list you in a minute. And for lymphoproliferation, you may want to look at ALT serum markers or B12 levels beside the specific immune subsets. So here are some of the key immune subsets that I recommend to be monitored in patients with immune dysregulation and CVID. And they will sort of lead you down a path of certain type of disorders. And I'm just going to list a couple of them. For example, transitional B cells. We discussed it last night. These are these early B cells that just come out of the bone marrow, and they would be getting more metabolically quiescent to go to the naive stage. When you have a very high activated mTOR pathway, they cannot do that transition, so they're going to start to increase with disease. So transitional B cells are perfect markers for APDS if you see them abnormal. We're going to touch on the CD19 high 21 low B cells that are T-bag positive. This is the area of a lot of research in autoimmunity and CVID. Of course, you want to get switch memory B cell compartments, naive memory T cells, potentially follicular helper T cells that parallel the 19 high 21 lows. And then we have very unique subsets that are pointing towards CVID-like disease that have more IPEX features, ALT features, or REC-specific features. Regulatory T cells gonna point you towards the IPEX route. The TCR alpha beta positive double negative cells are gonna be more ALPS-like. And then I have a special, as I told you, REG is close to me because of my research, and we have a mucosal-associated invariant T cell compartment with alpha 7.2 that is REG specific that I can use in my diagnostic to sieve out the possible REG patients from CVID. So these are, yeah, please go ahead.
I just ask, is there a standardized lab? Obviously, you can do this in-house.
Yeah.
In our hands here, it's been variable on what's done. Some of these you have to add on, like double your T cells. What is the best approach to sort of, as we move, for example, from targeted sequencing the whole genome, what's the equivalent for flow?
Yes. So this is basically a big debate because currently the only panel that have been validated for immune dysregulation are the OPS panels that you can see at Mayo Clinic, at Cincinnati Children's. And that is very rudimentary. You basically have a double negative T cell compartment and the activation of those cells as a marker. And most hematologists actually get falsely reassured if they have a normal OPS, so they don't have to move forward in the evaluation of the patient. So in my conversation with Pharming on ad boards, I'm really advocating for a more comprehensive so-called APDS or immune dysregulatory panel that clinician could just obtain like what I listed here, and have a sense of the patient's immune phenotype and where the dysregulated compartment is. Unfortunately, we are not there yet, but this is why I keep on pushing it on my slides, because the need is there, and I agree with you that we should make it easy for everyone. Why do somebody have to go to 5 different labs to order 5 different tests when there could be one test to cover it all? So yes, I agree with you. And then, of course, in the genetic evaluations, you're going to look at some of the top genes, the NFKB1s, CTLA4, LRBA. I care about REG. But we also want to look into some of these syndromic patients. So it's not uncommon that we have patients who come in with a very unusual look on their face, just dysmorphism. And we have to figure out, is this hypogammaglobulinemia related to that dysmorphism? It could be the George. Kabuki syndrome is surfacing now. WHIM syndrome, as I mentioned to you, have actual targeted therapy with CXCR4. And then some of the APDS short syndrome patients. I also recommend that genetic testing is repeatedly evaluated because, as you know, and I'm going to show it, there's an exponential increase of monogenic disorders in CVID. So this is actually one of the nice figures that Xiao Peng has published in 2023. And last night we were discussing a patient who actually was sequenced in 2005. And I don't know if you can see my cursor. Yes. In 2005, you can see that the total number of genes that was linked to CVID as of now was only 6, right? So if you had a patient in 2005 evaluated for CVID, that's a very different panel than if the patient was seen in 2022. And by that time, you had 70 different CVID genes to be considered. And I highlighted a couple of the important ones that I personally think we need to be aware of, which is the one that will need targeted therapy or are unique for their syndromic features. Yeah.
So obviously the number of genes has grown rapidly. The proportion of patients with CVID or CID who can attribute to a single gene, I mean, it was like 15%.
Yes.
Do we know what that number is today?
Yes. Yes. So the question is, just to reiterate for the audience in the room, is that has there been a change in the proportion of the discovery rate of CVID genes, monogenic genes among the big population of CVID patients? So the next paper that I actually highlight here from Peng and Dr. Carlos Charlotte Cunningham-Randall actually is addressing that. And they were looking at the big CVID population and see where did you have a very high rate of monogenic cause. And I don't have that figure in my talk, but they found that patients with immune dysregulation, especially lung disease, autoimmune complications, were enriched for monogenic cause, and it could go as high as 30 to 40%, whereas patients who have a low rate of non-infectious complications and tend to do well on immunoglobulin therapy alone have a lower rate of monogenic causes that we can find. But I do want to caution to not to avoid genetically sequencing those patients, because maybe they are early in their journey and eventually they will have non-infectious complications. And if you find them early in their journey, maybe you have a better chance of controlling the disease or preventing autoimmune manifestations.
And also just to that point, because Charlotte taught us 5-10 years ago sequence everybody.
Yeah.
Now we have so many more genes. When you think about resequencing or reevaluating prior to that, it's something you should look at every couple of years.
Yes, I certainly think so. Even in my own practice, the whole boom happened with Invitae maybe 3-4 years ago when everybody got available testing, free testing. And I am reassessing patients, even those who got that testing 4 years ago with a 200 plus panel. Now we have nearly 600 genes. So I basically try to make sure that every patient gets that highest level of 600 gene evaluation. Yes, I reorder it because that's probably the most acceptable route by insurance. We know that big academic centers, Baylor, New York, they want to have everybody whole exome or whole genome sequence, and there are trios actually now when the parents are sequenced at the same time, so you can decipher some of the interesting variants. But it is unrealistic in Florida, so we try to go with whatever we can do on a regular basis, and even just getting your team by it, like your nurses and your MAs and people who are on the ground getting those swabs and sending them out. You have to make sure that people see that there is a reward and it's not too hard to get it done. Yeah. Yeah, so if you want to take home one gene in your practice from my presentations for CVID, take home NFKB1. NFKB1 is the most common gene currently based on the European cohort. So if you see an NFKB1 in your report and it is a variant of uncertain significance and it's a CVID patient, don't pass it. Think about that variant because NFKB1s are often going to be VUSs. I have several patients who came to me with a variant of uncertain significance in NFKB1, and the clinician was unsure whether they would take it seriously. So then we had to do all the legwork of figuring it out, and it really allowed the patient to go much further in their diagnostic and treatment journey.
What percentage is the number one gene? What percentage of patients have that genetic abnormality?
In all CVID patients?
Yeah.
I don't know the exact frequency, but if you think about like 30% of CVID patients having a monogenic cause, I probably would say in my practice at least 5%, 5 to 7%, 30%. No, 5%. I mean, of the total population would have an FKB1. So, but we have actually expert in the room. Karin Chen is an expert in the NFKB1 and 2 pathways, so she may be able to give you more accurate estimates. So, but it is something that we have to get comfortable with.
In Florida, does insurance pay for this?
Yes, but we have to use the right language, and you have to document in your note that you are discussing pros and cons of genetic testing with your patient. It's a shared decision making because of the whole question about like genetic information, like being released to the medical community about the patient. We always say that it's only the immune genes that we are focusing on, that we are not looking at cancer predisposition. And it has to be very clearly spread out. They sometimes push you back and say that you did a genetic counselor visit before you can have the patient, or a geneticist before the patient can have genetic testing. And we try to fight that because we believe that immunologists sometimes have a better take on how to interpret a genetic report for a patient than a genetic counselor, since they are not familiar with this, big boom of immune genes that are discovered and how to functionally evaluate them. So we try to fight that, but you would probably hear back sometimes saying, did your patient see a geneticist? You send them to the geneticist and they don't know what to say. They don't understand CVID most of the time. I don't know if you have geneticists here who can actually communicate.
I don't know how the same experience, but usually, I mean, they'll sometimes assist with the sequencing, but then bounce back to us, like what to do with us, like in my experience.
Yeah, so you are really on your own in a bit, but we have a whole community of immunologists now who are helping each other to make sure that variants are resolved and centers that focus on certain variants or genes are highlighted in our listserv communications. Okay, so I think the pathomechanism of combined deficiency and immune dysregulation is actually very complex, and it is sort of an undulating way because in certain disorders, for example, reg deficiency, you would have the underlying problem is the repertoire, T cells and B cells. Repertoire is generated partly by the reg genes, and so the immune dysregulation would come from the fact that there's a lot of autoreactive B cells and T cells. In regulatory disorders such as EPASED, IPAC, CTLA4, the regulatory T cells are to fault, so they're not going to be putting the brakes on activation of autoreactive cells. And then you can also just have sometimes accumulation of autoreactive cells because they don't die in time. And some of them could be related to ARPs or EPASED or ARPIDs. And this whole complex process sort of escalates with age. So when you have a patient at 5 years of age with a mutation, they may look very different with their clinical symptoms and immune subsets than if you look at them at 35 years of age, because of all the journey that they took with exposure to antigens, debris in their tissues after not clearing infections properly, and then having a lot of inflammation because every cell would like to try to clear those infections and they are not as successful. So when I think of how a defect in T cells and B cells actually result in autoimmunity, that journey can be tumultuous. You can again have a problem with the repertoire itself. If you have an abnormal B cell T cell function, there would be impaired antigen clearance with a chronic inflammatory milieu. we actually will look at a unique B cell compartment. I'm going to introduce you to these T-bag positive B cells. Many of these are resulting in tolerance defects and eventually clinical autoimmunity developed. So every patient would have their own journey based on their own mutation or own disease, but in the end, you would see clinical autoimmunity. So let me talk to you about these T-bag cells. How many of you have ever heard about the 19 high 21 low T-bag positive B cells in this audience? Yeah, we discussed that quite a bit with Matt. So these are unique cells, and I want to emphasize them because it is really exciting about like how much they have done and not done properly throughout different disorders. So on the right hand side, you can see T-bag positive B cells accumulating in REG deficiency. This is a part of our Nature Immunology publication, and these cells express a lot of different markers, including FcRR5. They're activated, so they have CD95. Interestingly, they have less expression of BAFF receptor. And we know that in a normal circumstance, when they are our friends, they will just respond to viral infections. So when you think of an influenza infection in a human or a mice, one of the first responders are actually going to be B cells, but they are not the sophisticated memory type of B cells. These are early B cells that will try to expand and take care of the infection. They can polarize to Th1. With Th1, they are very sensitive to interferon gamma, also sensitive to TLRs, and the least sensitive to the BCR, like the antigen presence. And when the infection is over, they retract back to the spleen and they became a very small population. So in normal circumstances, they just come out in waves whenever there is an infection. But what we learned throughout the years that they can be our enemy too, because in case of an abnormal chronic infection such as HIV, malaria, or autoimmune disorders, including lupus, rheumatoid arthritis, Crohn's disease, and even CVID, they persist. And by persisting, they actually can become potentially antigen-presenting cells to the T cells. So they can start presenting autoantigens. They can become fast antibody-secreting cells. And if they have an autoreactive repertoire, that would mean that they would make autoantibodies. And they are very curious because they're actually the markers of CVID with complex disease since 2002. So we know of these cells. As much as 20 years ago, we knew of these cells, and we still don't understand fully how they function, what they do. And I think their relevance will span even other disorders beyond autoimmunity. I'm sort of postulating potentially even asthma. So I think these are very important cells that I would like people to get familiar with and follow them in the literature. So, yeah.
Go back a slide.
Yes.
The range of things in which they're abnormal is amazingly broad and unconnected.
Mm-hmm.
How is that?
Yeah. So I think of them as teenager B cells that don't have a full like commitment to a high academic path. When you would be a highly sophisticated class-fish somatically hypermediated B cell. So they can do so many things, but nothing well. And because they are easily like triggerable, right? You can trigger a teenager in no time. Whatever they have that transcriptome is about, they're gonna do that. So they can present antigens, they can become antibody secreting cells. And I think we even see some phagocytic properties in them. So this early B cell compartment is very plastic in one way and is dangerous. Now, if it was a normal controlled circumstance with a low interferon signature, they would come down and go back to where they belong. But if you have very high interferon signatures around them, then they're constantly activated, and TLRs and interferon gamma are how they survive. So it's basically like a very sort of non-specific but potentially harmful B cell compartment that was meant to do innate-like responses. Does it make any sense? Yeah.
No more than I.
So I was trying to wrap my head around it. I think I'm still learning about these cells, but sometimes these early cells that you would think that they only do so much and they should go away are the troublemakers because they don't go away and then they do damage, right? So when and how to treat these immune dysregulations, I'm just going to take you to this journey of treatment options for them because I would like to give you some examples, actual clinical cases for you to take home. When you have a patient with this conundrum of different features of immune dysregulation infections, they come to you and then you do a physical exam. There will be some lab testing and imaging. But eventually you have to treat, and your treatment options are extremely diverse. You can go with a lot of targeted therapies. There are biologicals available. You can even decide to do bone marrow transplant for them. So when do you decide to do that is up to you. Sometimes if you think that the patient is responding to immunoglobulin or a little bit of rituximab, you are comfortable. But if they are, because they're going to become asymptomatic, but if they are treatment refractory and failing the therapy that you are using, then you have to make some decisions. And I think this is why it is so important to do genetic testing. So let me go to REC deficiency as a poster child of these disorders. In REC deficient patients, we see both immunodeficiency infections and autoimmunity. And just a reminder to the fellows in the room who are maybe online, recombination activating genes are creating a heterotype tetramer with REC1 and REC2, 2 copies of each. They are binding to the DNA at certain sites and nick the DNA open. REC2 is going to stabilize this whole process, and this process will enable the DNA to recombine repeatedly. And that's how you actually create the repertoire. So the T cell and B cell repertoire is the byproduct of the VDG recombination process. And during that process, the goal is to have as many different T cells and B cells to recognize foreign, I mean viruses and bacteria, but to not recognize self, because we don't want these B cells and T cells to attack the body. So REC not only diversifies the TCR and BCR, but also has a second process called receptor editing, where it rearranges one more time or several more times if the receptor is autoreactive. So it's a very important gene in creating diversity of T cells and B cells, but also playing an important role in tolerance. So now I'm going to show you a case of a patient to illustrate to you the importance of finding REC deficient patient. This one was published in 2010 by the NIH team. This is a 2-year-old male who had, at 2 years of age, had ear infections like everybody else, but also developed some nail bed fungal infections. The patient had myasthenia gravis, and the neurologist decided to start pyridostigmine for the low IgG that they found, low IgG2 and 4, and poor pneumococcal response. He was on replacement therapy. So they found immunodeficiency and autoimmunity pretty early in his life, but they couldn't go much further. However, the patient progressed. And at 10 years of age, he had dysphagia, he had more pneumonias, and developed non-healing granulomas. In fact, you can see here that in the palate, he had so much destruction from these granulomas that it perforated his palate. And he had also a saddle nose appearance because his septum was perforated. So at the age of 13, or at the age of 10, he had thymectomy for non-responding myasthenia, and 13 years of age with this destruction of the palate and the septum, they also started to put all sorts of medications, immunomodulation on him, just the kitchen sink with Dapsone, methotrexate, infliximab, and steroid. By the age of 15, he had basically no T cells and B cells, and he also had a lot of therapies that could have suppressed them, rituximab, cyclophosphamide, IV steroids. So you are seeing a patient, a 15-year-old, who has major facial destruction. His immune system is very low, and lo and behold, was found by the NIH and never had a full understanding of the underlying cause. So what happened?
Did he progress because it progressed naturally, or did he become more immune deficient because all the therapies?
Exactly, and that's the question that everybody asks when they are taking care of patients with these autoimmune disorders. Is my patient naturally progressing into more immunodeficiency because of the medication I'm using, which is secondary immunodeficiency, or was there a primary cause that made the patient refractory to therapy? And in my mind, if you see a patient who is refractory to treatment and conventional therapies are not working, to me is a red flag, because then you probably have something more than just a disease. So in my mind, it's a combination, of course, of both. And you cannot dissect it now because the patient is immunomodulated on so many levels. So the only way to go about it is through genetic testing. because you have no other way of understanding the immune system since it has gone through so many modulation with time, right?
Yeah, but even genetic testing is not going to necessarily tell you the natural progression of the disease. It's variable.
Yes, yes, it will not tell you the natural progression of the disease, but it may give you different tools to treat the patient on that journey, which I think sometimes is very important because right now it was treated as if it was a rheumatological patient with a severe rheumatological disease, but nobody really looked at the immune side besides giving immunoglobulins. So the patient had a family history actually with a sister who had autoimmune cytopenias, ANA positive collagen vascular disease, and died of a staphylococcal pneumonia and sepsis. So with that second history and the patient's own journey, I think we rightfully can say that there could be something in the family, in the genes, that is inherited. And lo and behold, at the age of 19, the patient had genetic testing and was found with a RAG1 compound heterozygous variant, and that made him eligible for hematopoietic stem cell transplant. So this patient had a very late diagnosis at the age of 19 of a Squibb gene, a combined immunodeficiency that could have probably maybe altered his disease course had he had the knowledge of his disorders before time. And the sad part of the story, and this is not published actually, that the patient committed suicide after all these interventions. And the transplant went well, but he had so much effect on his body that he could not take it anymore, and he had a mental disease from this long journey. So I think this is just telling you, again, the importance of understanding the root cause as early as possible so you can influence the patient's clinical course better. And that takes me to this other paper that we published from Harvard. I was taking care of this index case, actually. You can see she's a female, followed by the rheumatology service. As a fellow, I had to cross-cover for rheumatology, so I had a little bit of that taste of how rheumatologists think about patients. And so this patient had destructive vasculitis of the fingertips. You can see that there is very minimal blood flow in the fingertips at the age of 6 months, had inflammatory myopathy, and recurrent sinus disease. And there was some immune phenotyping going on. They found that the patient has CD4 lymphopenia, normal B cell count, has repeated treatment with rituximab because of the presence of antiphospholipid antibodies, got steroid IVIG and Lovenox, and she died at 31 months of age after a stroke and sepsis. And this was at the time back in 2007 and 8 when I was a fellow there, and there was no apparent thinking of genetic testing at that time, even in the best institutions. So interestingly, the patient's sister was identified by the Spirals kidney 1 screening with T-cell lymphopenia. So we found an asymptomatic child in the family who had, all she had is T-cell lymphopenia. But with the family history and the concern, we actually performed genetic testing on this child, and she was also found with a RAG1 compound heterozygous mutation. So this asymptomatic baby at 4 months of age or 3 months of age underwent bone marrow transplantation and doing well. And again, we don't know how would she have fared compared to her sister, but obviously we gave her a chance of having a brand new immune system and doing better throughout life. So now I'm going to take you to this clinical presentation phenotype of RAG deficiency, which I find very fascinating. Many of you probably think of RAG deficiency, especially those who are in the lab, the RAG knockout mice, as a SCID or Owen syndrome phenotype. On the left, you can see that these are the T minus B plus or T plus B minus phenotype. But as of 2008, there is this new phenotype that is surfacing. The case that I presented to you from the Ravin and Katarina Schutz in the New England Journal of Medicine has published a case series of patients who had RAG deficiency and had B plus phenotype. So now we basically have patients who are like CVID-like. They are not having a full absence of B cells. They have a T cell presence, they have a B cell presence, and they actually have later onset infections. They have cytopenias and granulomas. And in 2015, we published a case series of them, 13 patients in JCI. And what we learned in that case series is that against the fact that these patients eventually got diagnosed with RAG deficiency, the overall survival was only 61%. So this cohort was definitely like less diagnosed in time and treated well compared to even a SCID patient. So what we are facing is a conundrum because we would think, oh, we found the most severe form of immunodeficiency SCID, we can do newborn screening for them. And now we know that there are other patients who have CVID, who have REG genes, and they may be out in the community and they may not even be potentially picked up by newborn screening. So we have to keep it in mind because they probably deserve sometimes bone marrow transplant as much as the SCID patients. So what we also know is that those who have a clinical phenotype of combined immunodeficiency have a more preserved activity. So there is some clinical phenotype recombinase and genotype correlation. So, but what to do about bone marrow transplant? The one who are T minus B minus and T plus B minus, the Oman syndrome and SCID, they will be transplanted, no question about that. But who's going to transplant these older patients and who are really deserving bone marrow transplant is still an undergoing question. So here, I just want to educate you. It came up in several of my talks that people didn't fully understand the REG recombination activity levels. When you have a patient with REG deficiency, you have to have two allele affected. So it can be either homozygous or compound heterozygous, as you can see here. And those recombination activities tend to like combine in a way to give the final activity level in the patient. And the CID patients can have as high as a 40 to 50% recombinase activity. So just half of normal. That's pretty impressive because we are not talking about a zero recombination activity that you can see in SCID or a 5% as it's seen in Oman syndrome. Other fun facts is that REG deficiency is the second most common SCID gene and the first most common atypical SCID gene. So the more atypical you become, the more likely that REG deficiency will be among the top genes. And the frequency is actually pretty high among some of the founder variants. So we work with patients from the Middle East, Irish travelers in the US, Mennonites, and Slavic patients in Eastern Europe. So when I think about REG deficiency, I want to reiterate of what can go wrong in a REG deficient patient. First of all, you have an abnormal T cell and B cell repertoire that will create ineffective clearance. And that will increase the antigen load. You will have viruses and bacteria and fungi, sometimes even translocated microbiome. And then there will be ineffective tolerance filters. Whatever T cells and B cells are abnormal and autoreactive will not be pruned properly. And that that persistence can relate to red blood cell platelet antibodies and oligoclonal autoreactive T cells. And they can be connected. So it could be like a vicious circle. Some of our patients, I believe, are going through these circles and eventually declare more and more disease because of their clinical history and exposures. So in 2022, we went on a journey and published on patients with REG deficiency regarding their polyreactive repertoire or autoreactive repertoire. And what we have seen is that patient one here in the middle, who was a newborn, only 5 months old with a REG deficiency, had only 18% polyreactive clones, whereas other patients who were already farther in their journey had way more polyreactive clones. And we wanted to look at and see why is there a difference between children and adults with their tendency for autoreactivity. And what you can see here is that those patients who were already adults, they had way more somatic mutation in their BCR. They had more polyreactive clones, as if something was pushing them into that direction against the fact that their recombinase activities were comparable. And what we have seen is that there could be modifiers in the periphery, modifiers of peripheral tolerance that can potentially let these autoreactive cells to expand. And that sort of links us back to this whole naive B cell compartment that we talked about. And these modifiers could be EBV, CMV, endotoxin with microbiome translocation, or even there is a question whether BAF is important in this process. So what you can also appreciate here that the older the patients were, the more likely they had these modifiers in their serum. So what I was hoping to show in this paper is that tolerance is plastic, and tolerance filters only work as much as they can based on the environment of those immune cells. And not everybody is set for the same journey. Their journey could be modified by the clinical exposures and maybe other genes, modifier genes. So it is very hard to predict where everybody is going, but by monitoring them regularly and looking for these modifiers in the environment may be a clue to see who is at risk. These are just these, unique B cells that we have shown in the spleen of the patients. And I'm gonna close my presentation with a case and an adult series, because I would like to show you that this is a disorder that is existing right among us, among patients in plain sight. This is a 34-year-old vet technician that I actually follow now in Florida, who was always known to have asthma and had difficulty with pregnancy and had a recent ICU stay. This is how she came to me with this history and nothing else. And when I met the patient during the pandemic, we actually realized that she did have a couple of infections, but nobody was excited about it, 3 to 4 sinus infections per year. In 2020, after she was in the ICU, they did an imaging of her lungs for the first time. Nobody imaged her lungs before for asthma, and she had bronchiectasis. But then, getting a deeper clinical history, she did declare that she had proximal joint arthritis, had extensive vitiligo organ alopecia, and I could not appreciate it because she was fully gone and had her shawl on. So you had to prompt her for these questions. Had HSV and VZV infections, infertility, and has been seen by 3 different pulmonary groups before they came to us for evaluation, pulmonary allergy groups. So in the first evaluation, we saw normal IgG and subclasses, low pneumococcal titers, so sub-Q IgG was initiated. But because she was only specific antibody deficient and an adult, insurance kept on rejecting her immunoglobulin replacement therapy. So we had to do several pneumococcal challenges and several evaluations. So at the age of 34, she was a patient with specific antibody deficiency.
How did you get approval for sub-Q IG and someone with normal IG and subclass?
Because she had specific antibody deficiency with low pneumococcal titers. And this is the weakest argument, right? We got pushed back every time, but she had a bronchiectasis and she had an ICU for a bacterial viral pneumonia. So obviously something is wrong with her antibodies. Something is not good, but it's sometimes not good enough for insurance. And even us, sometimes we are not that convinced that these patients need immunoglobulins, right? So Tara Seiko, who actually was an allergist, one of our trainees, just got out of fellowship, got concerned about this patient. And she asked me on the phone, what should I do about this patient? Should I do something more? And we agreed that we should look at maybe her lymphocytes, right? Let's see what her lymphocytes show. So we looked at her lymphocyte count, and her absolute lymphocyte count was low. She had low CD3 T cells and low CD19 B cells. So now we have a patient with specific antibody deficiency and lymphopenia at baseline. That to me is again another red flag that this patient is just not like an easy immunodeficient case. So what would be your next step in this case, in your own practice? What would you do to evaluate this patient for their immunodeficiency? B-cell flow cytometry, okay. Any other thoughts? Sorry? Genetic testing, okay. Would you do the flow before the genetics or the genetics before the flow? Who is voting for genetics first? I'm sorry, at the same time?
What did Anya say?
Yes, whether you would like to do genetics before flow cytometry or the way around. So you may remember that I told you that every CVID patient would deserve 3 different tests in my mind in their lifetime. One is the B-cell count, the second is the naive T-cell count, and the third is genetic testing. She's not a CVID patient by the book, but I think she would deserve these 3 assays herself. We know already that the B-cell count is low. We don't know much about the naive T-cell count or the genetics. Yeah? Yes, so the question here is, so the question is whether naive T-cell ratio changes with age. And that's true, like an infant should have a naive T-cell compartment of 95%. And an adult probably should have around 40%. So there is a natural decline of naive T cells because the thymus is getting less and less active and there's involution of the thymus. But if you have a 30-year-old with 10% naive T cells, that's low to me. So you have to just understand what is the natural progression of naive T cell count decline? And is this below that progression? Or if you have a 3-year-old with only 20% naive T cells, that is concerning that there is a problem with the timing development of T cells or T cell development. Yeah?
Was there any other family history for this 34-year-old?
The family history was completely negative. Yes, yeah, but very good question. So when me and Tara were talking about it, and she was just a half an hour away from me, from my center, and I told her, think about the naive T cells, look into T cell proliferation, or look at genetic testing. And she actually opted for genetic testing. She said it was so hard for her to send out that naive T cell compartment. It is so hard for her to get proliferation studies accurately done that she just went for genetic testing. So this was a genetic testing result of this patient. She had 2 reg mutations, one coming from mom and one from the dad. Both of them were hypomorphic variants with a relatively high recombinase activity of around 50%, 42 and 58, and they were both reported as pathogenic. So does it change your mind about this patient? Now you basically shifted the diagnosis of a patient with specific antibody deficiency and lymphopenia to a monogenic combined immunodeficiency with immune dysregulation, the secondary to partial deficiency. And it has major implications, in my mind, for a patient when you have a new diagnosis, a new understanding of the progression of the disease. So we had several conversations, and my biggest concern for her was her lung disease, because we already saw bronchiectasis, and what we have seen in reg deficiency is that with age, many of our reg patients would move from pneumonia to bronchiectasis and granulomas, fibrosis, and COPD. And I'm aware of patients in their 40s who had been on oxygen because they had such a progressive inflammatory lung disease. And because of these circumstances, we started conversation for stem cell transplant for this patient at the age of 32. So major point was that she has bronchiectasis, she has severe lymphopenia and recurrent herpes infections. And the minor points that we found her with the anti-interferon alpha antibodies, and this was during the COVID-19 pandemic, and there were some publications saying that when you have these antibodies and you get COVID-19, you could have more worse outcomes and a severe clinical disease. She has antibody deficiency, and she really had a very poor quality of life. She no longer could work full time. She started to feel more fatigued. She had joint pains everywhere. So to my point, she had definite signs of immune dysregulation. We had laboratory evidence of that too. So my indication for stem cell transplant was the potential progression of lung disease and the question of this immune dysregulatory process. So eventually the patient was transplanted with the help of Dr. Notarangelo, Limana Dimitrova, and Jennifer Conakry at the NIH on their protocol. And you can see that a year or two after her transplant, her vitiligo was slowly resolving, her alopecia was getting better. But most importantly, she became completely asymptomatic of immunoglobulins, improved T cell lymphopenia, very mild recurrence of the herpes infections. And then she experienced a mild COVID-19 infection after transplant against the fact that she had interferon alpha antibodies. So looking back, this was a huge leap of faith for us to take this patient to transplant, because she was at the beginning just one of those SAD patients from the community who always carried the diagnosis of asthma. And the NIH told us that they were very grateful for her coming at this stage of her life and not 10 years later, when she already would have so many comorbidities that the transplant outcomes could be way more poor. Any comments on that? I see you.
So, she had 3 workups by specialists before.
Yeah.
With 2 allergy, 1 pulmonary.
Yeah.
I guess the thing that strikes me is this specialty, the science is so complex. I doubt that any of those 3 workups came anyway close to knowing what was wrong with this woman. Right? So that even those who are trained as pulmonologists or hypersensitivity allergists, which most allergists do not know immunology deeply enough to come anywhere close to making a diagnosis for someone like this.
They don't, but on the other hand, I think they missed an important factor of the lymphopenia. So when you have a patient with low antibody features, but also T cell lymphopenia, you no longer can just assume that this patient is antibody deficient. You have to sort of go down the path of combined immunodeficiency evaluation. And that's what I try to hammer into every of my talk, because if you realize that low T cell count alone is a red flag for a different type of disease, and you no longer miss these patients. And you can let somebody else do the full workup or even help you with the genetic testing, but just having that alert in your head that, wait a minute, this patient is lymphopenic all the time and T cells are low. I think this is something that I would not want anybody to miss, no matter what specialty, what subspecialty they do in our field. Yeah.
I agree. I'm just not sure that we're training people in pulmonary and traditional hypersensitivity allergy
Yes.
to pick up these clues.
Yes, I agree.
Yeah.
I agree. And this is why I think, so the question here is that how can we teach our colleagues in pulmonary and hypersensitive pneumonitis groups? And I actually, for that reason, I'm designing a mouse model based on hypomorphic drug deficiency that will affect the lung. And I would like to understand lung disease and start conversations with these groups, because the only way to teach them is by collaborating with them and creating joint publication and avenues, and then maybe the field will eventually merge in some of these questions. So I know that we are almost at the hour, so I'm just gonna tell you about this whole question, which is a difficult question, and it was raised here, is who to transplant in adult drug deficiency. On the left-hand side, here you can see a healthy adult from the Mennonite community driving his carriage, and he has a homozygous RAG variant that is a 25% recombinase activity, so even half of the one that our patient had. And on the right-hand side, another patient from the same community, a female in the middle here, who also has the same mutation with 25% activity, has severe clinical disease. She had lymphoma, she went through lung transplant, and then we have the patient in the middle that I described to you. So how do you decide who to transplant and who to evaluate further and monitor is a big question. And to answer that, we actually have been working with the Mennonites. So this is Brent Ward, who is now in DC, who found this family, where you can see that the index case is a female, had very severe disease, but all of his brothers, these two brothers, are healthy. And then she had a sister who also died of chickenpox, West Nile meningitis, and other infections. So we created this cohort of over 20 patients, and we are looking at their progression of disease and how they potentially evolve. And what is beautiful about this cohort is that all the patients have the same mutation, and they are from the same ethnic group, the same environment. So hopefully we can start deciphering those immune dysregulation markers and triggers that can push a patient towards a more severe disease and need for transplant. What we learn in this population that the clinically well and the clinically symptomatic group has shared features of T-cell lymphopenia. So there is low thymic output with low naive T-cell count, and they have the hallmark of the decrease of the unique myeloid cell compartment that I mentioned to you at the beginning. What we learned is that the clinically symptomatic patients have loss of T-cell competence. There are more exhaustion of T-cells, and there is loss of tolerance regarding some of the B-cell 9921 low expansion. And they also develop some autoantibodies. So we think that maybe there would be certain markers that we could follow in patients regarding immunological and serological markers that can help with progression. So what I propose currently in drug deficiency in my field is that you have a genetic variant and you predict the recombination activity, but then you have to repeatedly assess the patient clinically regarding infection, dysregulation, and organ damage. You do this immunological phenotyping and biomarker assessment, and then you decide if the patient is well, you just keep on monitoring, and the patient is unwell, then you go to immunoglobulin replacement therapy and bone marrow transplantation. And we are now working on a prospective study to evaluate these markers more in a controlled fashion. And lastly, I do want to mention to you that we are fortunate to have a mouse model where we are looking into the same phenomenon, and we are trying to understand how, in an even more controlled setting in a mice model, we can induce immune dysregulation. And these are the new directions. So my conclusion is that CID with immune dysregulation is expanding in age, immune phenotype, and there are some early biomarkers on the horizon, including autoantibodies, plasma factors, and cellular changes. But genetic defect and mechanistic underpinning is very important in planning therapy. So we have to pursue the genetic testing, Progression of autoimmune disease could be prevented with early recognition, and bone marrow transplant can be an alternative treatment for alternative therapy for treatment-resistant cases. I am really grateful to the models, the Clinic for Special Children, many of our US collaborators, including Eric, Karin, and Maite here from these groups, many of our collaborators around the world. And thank you so much for your attention. These are our clinical people, fellows in training, and I know that I have to say the word of the day, which is immunodeficiency. Thank you for your attention.
Question? That was all pretty easy. Well, thank you so much.
Thank you. Thank you for all of you who listen.
Thank all of you who helped actually get this broadcast to work the first time in a new room, and those for coming. So thank you very much so much. All right, and take the food so I don't have to